Try again, Tanya, see if this works. So
I have tried it from my
working now, Tanya.
Working now.
It's working.
Working?
Yes, working fine.
Okay, good. Then I will be from my phone.
Perfect.
It's from my phone.
If you go on the Russian channel, you are put as the Russian translator. So if you put on the Russian channel, that will be great.
Just give me a second because I need to find it where it is.
There's a globe below, just next to the raise your hand. There's an interpretation globe on the
Yes, I'm trying to find it on my phone. Just sorry for this. It's like the first time when it's not working. I don't know. I'm sorry.
We're only 3 minutes late, so that's all okay. It's great to see people from all across the world. Just give us a couple of minutes. We're sorting out just the Russian channel, and then we'll be live with you. Sorry for that. Did you find it, Tanya?
Should I maybe leave? Сделай обратно, пожалуйста, как это было.
You need to turn your computer completely off.
Okay,
Otherwise,
translation, the Russian one. Yes.
Perfect. And if you're using only your phone, it might be worth turning off your laptop if your laptop is still on. Otherwise, can you hear me all okay now?
Yeah.
So you need to go on the Russian. So otherwise, we will keep on hearing you in the English channel. We should not be hearing you in the English channel. Are you on the Russian now as the interpreter?
Yes.
So no, let me. I think you need to disconnect the other one. Otherwise, you'll be still, because you're logged in twice.
Okay, I will.
Add interpreter. Because perfect. Can you hear me now?
Yes, I can hear you.
And I'll put you as Russian. Update. Can you make sure that you are on the Russian channel now, Tanya?
Раз, два, три, раз, два, три.
Okay, so it's still not working. That
can you disconnect the laptop, disconnect the computer, and use the iPhone or use?
She's using the iPhone now.
Yeah,
so,
but the computer is still I think, because we can hear.
No. Computer is off. The computer is off.
I need to redefine the Russian channel. That's perfect. Now, can you go back on the Russian channel now?
I'm there.
Perfect. And all of us, we need to go back on the interpretation and go on the English channel. And Ricardo needs to go back on the Spanish channel. And so we'll redo all that because I had to reset all the interpretation. Sorry for that. And are you on the Russian now, Tanya?
Yes, I guess. Have you signed me as a translator?
Yes.
You have assigned me as a translator. It should be working if you have assigned me as a translator.
I don't know why your phone is not working on the translation. Just a minute. I re-sign you again as a translator. Sorry for that. Update. Try again now. Perfect. That's working okay. So we have Ricardo and we have Tanya. Hallelujah. That's all worked fine. Welcome, everybody. It's great to see that there's 440 people already online. Apologies for the technical problems, but we are trialing 2 channels today. So we have the lovely Ricardo Pardo, and Ricardo is doing the Spanish channel translation with us today. And we have the lovely Tatiana, who's doing a Russian language today. So if you want to listen to the talks in Spanish, join Ricardo. There's a globe. Click on the Spanish option. If you want to hear it in Russian, you join the Russian channel with Tatiana. Otherwise, all the talks are in English. So we have a great 4 speakers, all on lobular cancer. We start with pathology with Emad, Rakha from Qatar and UK. Then we have radiology with Tamara, Suaris from London in England. Then we have Rita, Mukhtar from the USA on surgery, and they have oncology from Olga, Oikonomidou, and we have Martin Sanchez with us also for the discussion, and we have one of the usual suspects and the frequent offenders. We have Andreas Karakatsanis with us today. So we'll start with the talks first. We'll do the talks, and then after the talks, we'll do the discussion. We'll start with the Emad. Emad, the next
Okay.
15 minutes are all yours. Thank you.
Hello, everyone, and good morning or good afternoon, good evening. And first of all, I would like to thank the organizing committee, Dr. Yazan, for this kind invitation to speak about pathology of lobular carcinoma. Just lobular carcinoma are diverse group of tumors that share common features. All lobular tumors, they have loss of ecadherin function, and they have this cohesive growth pattern, means individual cells. The cells are not attached to each other. This is usually result in less tissue reaction. So you may have scattered tumor cells with multifocality, with extensive spread, and going to the lymph node without being clinically detected. This is because of the biology of lobular carcinoma. But in the talk today, I would like to highlight a very important thing, which is under observed in literature, which is lobular carcinoma is not one entity. Although it is different from ductal, but it is not one entity. And it comprises actually two main groups. First, in situ and invasive. The in situ have three entities: classical LCIS, florid LCIS, and pleomorphic LCIS. They are different. They are not the same. The same with the invasive lobular carcinoma. We have two entities: classic and related variants and the aggressive variants. And they are completely different. Although all share same features, but they have different response to treatment or different clinical behavior. First, start with LCIS quickly. The most common type of LCIS is called the classic LCIS. And usually this one is considered as a risk factor. It's not obligate precursor. It's not like DCIS. So it is a risk factor for future development of cancer. So usually we treat this not by surgical excision, but by follow-up. So if you have a classic LCIS on a core biopsy, we label it as B3 with atypia, and usually we do vacuum-assisted excision or vacuum-assisted biopsy just to exclude higher risk lesion, associated invasive, associated DCS, and so on. If we have LCIS on surgical excision, no need for margin assessment, no need to achieve complete excision. The second type of LCIS is called the florid LCIS. In the past, you will find terms like mass-forming LCIS or necrotizing LCIS. This type of LCIS was discovered when they found that DCS-like lesion, when they stained it with ecadherin, it was ecadherin negative. So it is lobular, not ductal. So on H&E, on morphology, they look like DCS. But when we stain it with ecadherin, it is ecadherin negative, and the family of ecadherin-cadherin family are negative all. So it is usually mimicking DCS, but we recognize it by being either mass forming without polarization, without cell architecture, or by presence of necrosis similar to Oikonomidou type DCS. But it is not high grade. It is usually score 2 for pleomorphism, so moderate degree of pleomorphism. The third type is this one. When we get florid LCIS, if it is a core biopsy, we code it as B4. So it's not typical DCS, but it's not classic LCIS. It's higher risk than classic LCS, lower risk than high-grade DCS or pleomorphic LCS. So until now, we consider it as B4, and we recommend the excision of florid LCS. And if we have excision, still, how do we need to achieve complete excision? Do we need to give radiotherapy? Still under a lot of controversy related to this. So it needs a discussion. Do we need completeness of excision, or do we need radiotherapy after excision of florid LCIS? No solid data, but you need to be aware that florid LCIS is higher risk than classic type LCIS. The third type of LCIS is called pleomorphic. We all know pleomorphic invasive lobular carcinoma. But pleomorphic LCIS as well is a variant of LCIS, but completely different from classic LCIS. Pleomorphic LCIS behaves similar to DCIS, and not only DCIS, similar to high-grade DCIS. So we recognize it on histology by being high-grade nuclei. So nuclei which looks like grade 3 cancer, grade 3 DCIS. And the pleomorphic LCIS, unlike classic LCS, usually can show HER2 positivity, can show ER negativity, so, and more frequently associated with invasive carcinoma. Management should be similar to DCIS. So if we have a diagnosis of pleomorphic LCIS, we need to ask for margin, and you need to discuss with the oncologist about radiotherapy after breast conserving surgery. Just, I know most of you are not pathologists, but this is the appearance of classic LCS, very bland looking, very small, very tiny, very good appearance. So we know it from the morphology. When we see something like this, we call it DCS, but you still need to see criterion completely negative. So it's called necrotizing LCS, or the current terminology is florid LCS. The other type of florid LCS, when it is mass forming, like this, it is like a mass. So, and when we assess margin, we assess from the mass lesion, not from the associated classic type LCS. So these are different examples of florid LCS mass forming, and this is criterion completely negative. And florid LCS like this one can be ER negative as well. So this is classic LCS, this is pleomorphic LCS, it can be ER negative. This is the third type, which is pleomorphic LCS. As you can see, it is high-grade nuclear. When we look at the cytology, we call it high-grade DCIS. And this one, as we mentioned, it should be treated as high-grade DCIS. By and large, the most important one is invasive lobular carcinoma. Invasive lobular carcinoma is the second most common special type of breast carcinoma. The percentage of invasive lobular carcinoma varies from 7% to up to 15%. They are slightly different from NST in the presentation. So it is older age, about 63, 60 plus, and they usually present larger size because it's not associated with tissue action. Maybe the patient will not notice, maybe missed on mammography. So usually it presents a larger size and more lymph node positivity than NST. Remember, as we mentioned, it is two types. One is the classic type, which is more indolent, more nice behavior, classic LCIS, and related variants. What related variants? It's called alveolar LCIS, invasive lobular carcinoma, papillary invasive lobular carcinoma, mucinous type, topolobular. All these are indolent type. They are 60 to 70% of the cases. However, we have 30 to 40% of the cases are classified as aggressive variant. These include polymorphic LCIS and polymorphic invasive lobular carcinoma, solid type and solid high grade, and very, very rare entities called the signet ring type. This is very rare, and histocytoid type. And both are aggressive but very rare. Those are about, as I mentioned, a third of invasive lobular carcinoma. They behave completely different from classic type. There are some, in our cohort, we have about 9,000 cases. We analyzed this, the group of tumor that were identified by the system as the most aggressive with polymorphic and solid lobular. So more aggressive than the matched NST. So although most of the discussion in literature about lobular focusing on the classic type, on the behavior of lobular, but and they don't focus on the aggressive type, but clinician should be aware that we have a subtype of lobular that behaves more aggressive than the classic type and maybe more aggressive than NST. The classic invasive lobular carcinoma, as we mentioned, usually present as multifocal, more frequently than NST, being multifocal, being positive margin when you have breast conserving surgery, because it can be extensive and extend more than what we see on imaging. So you can get positive margin than NST. Majority of classic is ER positive. So if you get a report of ER negative classic lobular, be careful. This is usually an aggressive variant, not the classic type. More than 95% of classic lobular ER positive and HER2 negative. I've seen occasional cases of classic invasive lobular, very rare, less than 4 or 3% of classic lobular are HER2 positive. So if you have HER2 positivity, just check the histology again. And the most important clinical feature is low proliferation, low mitosis. So when we have look at this, it is grade 1 or grade 2, luminal A intrinsic subtype, less likely luminal B, and the majority, if you ask for oncotype DX or other multi-gene assay, it will be low risk. Reported in literature, 1 to 5% or 1 to 8% of invasive lobular can be high risk with oncotype, but this is including all variants, so including polymorphic and solid and classic. So if you restrict classic type, the frequency of oncotype DX high risk will be very low. So if you have high risk tumor, just ask, is it lobular or not? As a pathologist, we look at down the microscope on the slide. So if we see single cell infiltration like this, we call it lobular carcinoma. And this is, if you see tubule, we call it tubulobular. So this is classic variant, this is tubulobular. And if we are in doubt, we stain it with E cadherin. This is the control, this is E cadherin loss. So the control is positive, the tumor is negative. Just out of interest, we have about 10% of lobular carcinoma can show E cadherin positivity. So still lobular, because we have the gross pattern of lobular, we call it lobular. If the pathology is in doubt, is it E cadherin positive? Is it ductal, not lobular? We can stain with other marker called beta catenin, and usually it is negative, lobular. So you can have 10% of lobular E cadherin positive, but these tumors, if you stain it with beta catenin, they will be beta catenin negative. The diagnostic concordance of lobular among pathologists is not very high, less than NST. So sometimes we use E cadherin immunohistochemistry to improve the concordance. And because of the this cohesive gross pattern, it's difficult to assess the extent of the tumor. So with measurement of the size is usually problematic for pathologists. I'll give you example of something. This is excision specimen where you have similar to in this area. It looks like lymphocytes or scattered cells of I cannot assess. I cannot see that this is cancer. This could be inflammation. But if you cut deeper level, you will see more of these cells extending into the background without any tissue action. And you look here, cytokeratin positive. Cytology, very bland looking, similar to macrophage or similar to lymphocytes. The classic lobular more likely to present as clinically N1 disease, no lymph node negative. However, they are associated with higher nodal burden than NST. So the frequency of BN2 or being stage 2 for lymph node, 4 lymph node or more is more than NST. So you have 4 node or more in 30% of lobular compared to 15% of ductal. So although clinically N0, not in clinical examination and not on imaging, but when we examine it under the microscope, we found more lymph node positivity in a lymph node which is not enlarged. And the frequency of non-sentinel lymph node in the sentinel positive lymph node is about 70%. So there are some data indicating that there is a 20% risk of clinical nodal under stage. So if you go with limited axillary surgery and rely on radiotherapy, remember that lobular can have a more lymph node positive than ductal, but not detected clinically. There is a talk in this webinar about treatment, but I just wanted to highlight something, that the response of lobular to chemotherapy is very limited. So in our experience, the pathological complete response is less than 5%. Or less than 5%. So it's not achieving even 5, compared to 15 to 20% in NST. So sometimes you use neoadjuvant for down staging. Even down staging is not achieved by chemotherapy. So sometimes even you don't see you see shrinkage of the tumor, but on histology, still scattered individual tumor cells present in the tumor bed or footprint. I'm not sure about the response to neoadjuvant endocrine therapy, but this will be discussed later. But we have maybe there is an option to use endocrine as a neoadjuvant. But remember that you have to weigh the balance between time for neoadjuvant and the degree of response. Because if you delay surgery a lot and the tumor is not responding, you increase the chance of distant metastasis. Lobular have unique metastatic pattern. So they go to the serosa, like peritoneal cavity, pleural cavity. They go to the endometrium, GYN. They go to GIT, so you can get it in the gastric, even with or after breast cancer, or even before as a first presentation. Less likely to affect the lung and the liver and CNS. And when you have metastasis, sometimes compared with NST, they have wider metastatic spread, so involving multiple areas. Regarding recurrence, early they have better outcomes compared to NST. However, after 10 years, they continue to develop event, as we can see here. So lobular early, they are better than NST. But with time, they continue to develop event, continue, while most of the ductal develop events early and then they start to plateau. So long-term outcome for lobular is worse than ductal. So early outcome is better, long outcome is worse. So you need a longer follow-up time. What about the aggressive variant? As we can see from this image, either very high-grade nuclei, so this is aggressive tumor, aggressive, I mean, this is not nice lobular of lymphocyte type, or very high mitotic count and solid growth pattern, which is grade 3 tumor. These are aggressive variants. So the aggressive variant, we classify them either polymorphic by high-grade nuclei, solid by usually high mitotic rate, histocytoid and signet ring, very rare, no data on literature, but our limited experience with these cases are usually very bad. Metastatic very easily. So if you have, and these are tended to be ER negative, histocytoid and signet ring, majority are ER negative. In general, polymorphic and solid are more frequently than the classic type to be ER negative and HER2 positive. 10% or more can be HER2 positive. Importantly, they have high mitosis, high proliferation. So if you have oncotype DX, you may have high risk. So this is good because you identify this high risk. So you know high risk and the lobular, it is likely to be the aggressive variant. The survival is much less than the classic variant, and even is when you compare with NST is usually worse than great matched NST. So we need clinical trial for these variants and to highlight the fact that lobular, they have a specific behavior and response to treatment, but they are not one entity. They are two completely different entities. So until now, these can be treated as high-grade NST, but it may be better to avoid neoadjuvant chemotherapy even if lobular is ER negative and HER2 positive. Because until now, the data on response of the aggressive variant to chemotherapy is not clear. There is no sufficient evidence. So it's better to have surgery, and then you treat this patient with whatever treatment, even if they are ER negative and HER2 positive, compared to NST. Because in some places now, if the tumor is HER2 positive or ER negative, NST, they start neoadjuvant treatment. So in conclusion, lobular carcinoma, it is distinct. They have a distinct biology, but they are diverse group of tumors, including in situ and invasive, and each one have at least two or three sub-entities of different clinical behavior. And the lobular is different from the most common type, NST, no special type, and different among the lobular. And remember that lobular can present a diagnostic challenge to pathologists. So it's not easy, and sometimes even we refer mixed ductal and lobular. Sometimes we use ecadena, sometimes we don't use ecadena. So you need to be careful if you have a tumor that doesn't match clinically, like ER negative classic lobular. You need to ask the pathologist, are you sure it is classic lobular? It's not aggressive variant. Are you sure ER is negative? It's not false negative, and so on. And remember, this is the most important for you to remember that less response to chemo, long-term outcome is worse, and make sure that we will have discussion about the imaging because they have a specific pattern of presentation on imaging. So which image modality you should use, like MRI or contrast-enhanced mammography. And in fact, remember, invasive lobular carcinoma is a heterogeneous disease that deserves more clinical trials. And thank you. I will stop here. Thank you very much.
That's a great talk, Emad. Thank you for that. We'll take all the questions towards the end, but we already can see that there's about 8 questions in the Q&A section, which is unusual to have so many questions even after the first talk. But you raised few points that will be hopefully addressed in the talks to come. The next speaker is Tamara Suaris, who's one of the radiologists in Barts in London, and she's going to talk about radiology. Do you want to stop sharing your slides, Emad, so that Tamara can share hers? And it's great to see more than 600 people online already. So today we have the Spanish channel with Ricardo, and we have also a Russian channel with Tatiana. So you can join any of those. And if you have any questions, please put them on the Q&A section. We'll go through that at the end. Tamara, the next 15 minutes are yours. Thank you.
Great. Thank you, Yazan. Thanks for inviting me to talk on this panel. Hola, здравствуйте. This evening, I'm going to talk about lobular breast cancer, the imaging appearances. Now, this is a huge topic, so I'm going to focus on just a few basic points. I'm not going to cover the pathology because Emad has done that very well, but it's obviously very important as to how we understand the best way to image lobular cancers using the various modalities we have in radiology. And I will touch on metastatic disease as well. So, as Emad has already discussed, it's a very common subtype. Between 5 and 15% of patients will have lobular cancer. And because of the difficult way and the discohesive infiltration that they move through, the imaging appearances can be extremely challenging. And it means that we have a variety of different imaging presentations. So let's start with mammography, which is still the established screening tool in most countries. And mammography has an overall sensitivity of between 50 and 80%. And this is obviously going to be affected by the breast density, where that sensitivity will significantly reduce. The most common presentation is with a spiculate mass or a mass with indistinct margins. And then the second most common presentation is with an architectural distortion. We often learn that lobular cancers might only be seen on one view, and most classically the craniocaudal view. And with the other MLO compression, it's just not easily identified. It's not creating a mass effect as an invasive ductal carcinoma might do. So it spreads out and is less difficult to appreciate. We may well see it as a focal asymmetry on two views. And you must, as a radiologist, look at several mammograms, as many as you can going backwards, because you may miss the gradually shrinking breast appearance that can only really be seen over looking at several mammograms. Less commonly, we might see microcalcifications or a rounded mass or nipple retraction. And you must remember that between 8 and 16% of the time, we won't see an abnormality at all, and it will be occult. And in those cases, it might present with an axillary mass. This is a case which demonstrates the subtle nature of lobular cancer. I don't know if there are many radiologists among the delegates watching, but here we can see a mammogram that isn't particularly dense, but there is a subtle asymmetry seen in the right upper outer breast. And what's important to appreciate here is that the density of this mass, which was seen under ultrasound, this lesion was seen under ultrasound, biopsied and proven to be lobular cancer, its density is about the same as the normal glandular tissue. So we need to be very careful and cautious looking at these subtle asymmetries, and we may need to call these back from screening. Another technique, digital breast tomosynthesis, which is now quite widely used and in some countries is used as a screening tool, does improve the detection of ILC. And that's because we see spiculation and an architectural distortion much more clearly with DBT. And we know that it's better at identifying ILC, and it can increase the detection rate from, will double it essentially, from 0.27 to 0.55 per 1,000 in a screening cohort. And it's even more useful in dense breast situation, where we might also double the sensitivity using DBT from about 40% to over 80%. But what we know about DBT is that, as with mammograms, and I actually failed to say this, but I think you all know it, we fail to assess the tumour size of the lesions accurately with both mammograms and DBT. If we use pathology, histopathology, as our gold standard, and Emad has indicated that it may not be easy to be really accurate, even looking at the histopath, a size after a surgical specimen, but we still fail and are quite far short of getting a true size assessment with either mammogram or DBT. Here I'm just showing a case where this was a subtle screening pickup, the DBT images show a subtle distortion that is better seen on the CC view, but you can see how easy it is to miss. It was a very subtle picked up because of a subtle change from a previous mammogram. But DBT will improve our cancer detection rate. Ultrasound sensitivity is better than mammography, but again, because of the infiltrative nature of the lesion as it grows, we also fail to adequately assess the tumour size with ultrasound. We most frequently see a hypoechoic irregular mass with posterior shadowing, and it may just demonstrate angular margins and posterior shadowing with textural change without a discrete mass. And again, as with mammography, it may be sonographically occult. We had a little discussion about this in the previous talk about the axilla, and we know that ultrasound has a lower detection rate for picking up axillary metastases in ILC when compared with IDC. And what we tend to see is a diffuse cortical thickening on ultrasound, and it's less likely to actually produce that eccentric cortical bulge that we often see with IDC. And because there's less mass effect in the cortex, it also reduces the appearance of an abnormal or loss of the hilum. And so we often will only see ILC metastases once the burden is really quite extensive. So this is from a radiographics paper, and it's just a schematic that shows how a metastasis might look in IDC. There's a mass sitting in the cortex, and we can see that abnormality quite clearly on ultrasound. But with ILC, we have this infiltrative pattern. This is much more difficult for us to pick up. And what it means is that we need to be much more cautious when we're scanning. It may be that we don't realize that we won't know that a patient has ILC at the time we're assessing the axilla and potentially doing a biopsy, but we need to be cautious and potentially go back to the axilla and biopsy what may be a subtle node that we may have missed the first time round. Pre-operative MRI. Now, MRI is one of the best tests. We know that it has a much better sensitivity, the best sensitivity for picking up cancer of all of our modalities. And this is true for ILC, and it's particularly important because it has a more accurate tumour size assessment than compared with mammogram or ultrasound. And importantly, MRI enables us to pick up those additional multifocal, multicentric lesions and also bilateral disease. And bilateral disease has been recorded as being between 7 and 10%. So this is contralateral occult disease. And we do pick up a lot of additional lesions with MRI. Not all of them are malignant. And there is a bit of discussion, and there has been some controversy in the past about the usefulness of MRI as a preoperative tool, whether it generates more surgical work than is needed. And I'm sure that Rita will talk about this in her talk. But we know that it often changes the surgical plan, often increasing what may have been a small wide local excision to a more extensive or a therapeutic mammoplasty or even mastectomy. But MRI does help us to improve the assessment of nodal burden, and we often go back to the axilla having seen something subtle on an MRI. On MRI, we will see a solitary irregular mass. We do see non-mass enhancement as well. And with the kinetic features, the important enhancement pattern that's key to picking up cancers on MRI, we will often see a delayed washout. So it's important to make sure you do the full sequence of the series of dynamic phases. including up to 6, because we want to make sure that we really see all of that enhancement. And as I've said, there has been some controversy over a number of decades over the benefit of pre-op MRI. But I think overall, what we've seen from the literature is that there has been no increase in mastectomies. Studies have reported both no reduction and no change in re-excision rates. So there's I think a local practice you need to watch what you're doing and really audit it very carefully. And for all of those additional lesions that we pick up on MRI, they need to be sampled preoperatively to ensure that we are performing the correct operation and we're not taking out tissue that turns out to be benign. Contrast enhanced mammography is one of the newer techniques, but is now pretty well established. It's a functioning imaging tool, so in exactly the same way as MRI, it utilizes that neovascularization of malignancy and it enhances, so we see them as these bright enhancing lesions on MRI, and we see them in the same way on contrast mammography. It's a mammogram plus an IV iodinated contrast, so the same contrast that we give for CT scans. The sensitivity of the study is also independent of breast density, which is really important and helps us to be much more accurate in size assessment, as with MRI. And it has been shown to have a comparable accuracy to breast MRI over a number of studies. But the one thing that's key is that we don't get the opportunity to look at the axilla, and we don't get the opportunity to really interrogate the pectoral muscle with contrast mammography. So that's an important thing to consider. And with ILC on CEM, we know that it correlates well, as with MRI, on the final histology size. And it, importantly, is significantly better than mammography at assessing tumour size. So this is a case demonstrating, you can hopefully see the eagle-eyed, there we'll see the hydromark clip in the left upper outer quadrant. There's a mass here, an asymmetry with some speculation at the margin and some distortion. And this is the contrast mammogram of the CC views. And you can see that the right breast looks entirely normal with no enhancement. On the left side, there is enhancement that is nodular and extending towards the nipple. If I show you both, I'm sorry, this should not be here. If I show you both the cases, you can see there's much more extensive enhancement. I'm sorry, that slide didn't work very well. But the contrast studies do show and correlate very well with MRI, and it allows us an easier opportunity to biopsy as well using contrast enhanced mammography. So contrast mammography and MR both slightly overestimate the tumour size, but are both much more accurate than our standard tests of mammo and ultrasound. MR has a slightly higher sensitivity, but accompanied with a lower specificity, and it's slightly different for CEM, which has a slightly lower sensitivity than MRI, but a much higher specificity. But we should consider contrast as an alternative to MR in local preoperative staging, and it's certainly much more accessible around the world. Certainly in the UK, CEM is much more accessible than MRI, but we should remember that it can't assess the axilla or the pectoral muscle invasion. I just wanted to quickly also just talk about metastatic disease in ILC, and again, because of its infiltrative rather than mass-forming pathological processes, it shows a less metabolically active uptake than IDC on PET-CT. And that may be seen on bone scans, and PET-CT is better than bone scans for lobular cancer. But you should consider other sites of metastatic disease outside of the normal areas that we would look, and you should consider looking at a peritoneal disease where we'll see a mental thickening. There will be potentially retroperitoneal disease with ureteral obstruction and hydronephrosis, and also potentially gynecological disease with adnexal lesions. Within the GI tract, there's also possibility of infiltration into the stomach and bowel, giving a thickening of the mucosa and giving this classical appearance of linitis plastica. And in the brain, we're much more likely to see leptomeningeal carcinomatosis, which is a leptomeningeal enhancement. It's very fine and nodular. We'll rather see this in ILC rather than intracerebral masses. So that's important to consider looking for all of these in a patient with known lobular cancer. So I've really raced through some of the important things regarding lobular cancer and imaging. There's a lot that I can't and don't have time to go into, but I'm sure we might be able to discuss that in the following discussion. Thanks very much.
That's a great talk, Tamara. Lovely overview of the imaging in lobular cancer. Now we'll go to surgery. So Rita will do her talk about surgery, and all the way from San Francisco in California. She's giving us the talk about surgery. Rita, the next 15 minutes are all yours.
Yes, thank you so much. Those two talks were really the perfect introduction to discussing surgery in lobular breast cancer, because the growth pattern of the tumor being diffuse combined with imaging having lower sensitivity for patients with lobular breast cancer really does lead to some unique challenges for patients. So I was going to start by sharing with you a case of a patient with lobular cancer and sort of what she went through in terms of her surgical management that I think kind of exemplifies some of the unique challenges with this type of tumor. I'll discuss some of the data on breast conservation surgery versus mastectomy and lobular breast cancer. And then I'll also talk about positive margins. And this is a major surgical issue that has impact on patients, and some of the techniques that might be well suited for lobular cancer and some of the considerations for the surgical management. So the case that I'll start with is a 75-year-old woman who was still undergoing screening mammography, and she was found to have a left breast cancer that was diagnosed as a mixed lobular ductal cancer. She had a right mammogram that was negative. In our practice, we do use a lot of breast MRI for patients who have lobular or mixed lobular tumors. So she did get a preoperative breast MRI. And on this MRI, in the contralateral breast, the right breast, which was negative on mammogram, there was a small area of non-mass enhancement that was seen, a 9mm area. This was biopsied with MRI guidance, and this turned out to be another invasive lobular cancer in her contralateral breast. So she had lumpectomies bilaterally. The left side showed a small mixed lobular ductal tumor, which was concordant with the mammogram appearance on that side. And in the right breast, she actually had a 4.5 centimeter lobular cancer. So this was 9mm on MRI and 4.5 centimeters on final pathology. She had positive margins. She then went on endocrine therapy for a period of time before going back to the operating room. She then had a re-excision, and on the re-excision, she had more invasive lobular cancer, LCIS, and again had positive margins. So we then took her back yet again, and we did a completion mastectomy. And on the mastectomy specimen, she had an additional 4.2 centimeters of lobular cancer, finally with negative margins, and a very diffuse growth pattern, as we heard earlier, with a very low tumor cellularity. So this case really is a good example of what any surgeon that treats lobular breast cancer, or any person who treats lobular breast cancer is well aware of these issues. These tumors can be mammographically occult. Although MRI is the best imaging test that we have, in many cases, it can still significantly underestimate the size. And patients with lobular cancer face high risk of positive margins, as well as higher risk of having to undergo multiple operations. And the literature really supports this: higher rates of positive margins, higher rates of mastectomy, and higher rates of axillary dissection. And the causes for this include the growth pattern of the tumor, the fact that by the time these tumors are diagnosed on screening, they are often higher stage at presentation. So patients are more likely to have larger tumors and more positive nodes. And there is a discordance between clinical stage and pathologic stage. So oftentimes surgeons are operating on these patients without knowing the true extent of the tumor. All of this increase in local regional therapy can increase morbidity for patients. So this is a picture of a patient who has lymphedema. When we start combining mastectomy with axillary dissection, with post-mastectomy radiation, as is often the case for patients who present with higher stage tumors, we are dramatically increasing the risk that patients will have long-term sequelae of these procedures. The literature confirms that patients with lobular breast cancer have higher rates of positive margins after breast-conserving surgery compared to patients with invasive ductal carcinoma or carcinoma of no special type. There's a range of positive margins, so some of the series are as low as 15 to 20% for lobular cancer. Some are as high as 60% for lobular cancer. But what is consistent is that the majority of the series always show that the positive margin rate is higher for lobular versus ductal cancer. And having positive margins definitely has negative consequences. So for patients, there's lower breast satisfaction and sexual well-being for those who require re-excision after breast-conserving surgery. Having to have that second operation leads to higher rates of surgical site infections, complications such as seromas and hematomas. There is increase in healthcare costs. And if these positive margins are not addressed, this will lead to an increased risk of recurrence down the road. So we might wonder, should patients with lobular breast cancer always choose mastectomy? And historically, mastectomy was recommended specifically for lobular breast cancer because of the diffuse growth pattern. But we know now that there are some disadvantages of mastectomy and some advantages of breast conservation, especially if people are going to end up having to have radiation no matter what surgery they undergo. More modern series also show that there are similar rates of local recurrence between breast-conserving surgery with radiation compared to mastectomy for lobular breast cancer. This is a graph showing the rate of breast-conserving surgery for lobular breast cancer. In 1989, a large series from a national cancer database in the United States showed that only 18% of patients with lobular breast cancer were receiving breast-conserving therapy. In 2001, that number was up to about 51%. In 2016, it stayed relatively flat. We really have not increased the rates of breast conservation therapy very much in the last 20 years for patients with lobular breast cancer. Some of the series show that it's up to about 60%, but it's always lower than for patients with ductal breast cancer. Being able to have breast conservation is now known to actually confer some benefits for patients. There have been several large series from multiple countries showing that patients who undergo breast-conserving therapy have the same or possibly better overall survival than patients who have mastectomy. And of course, there's going to be selection bias in patients who are able to undergo breast conservation therapy, but even when adjusting for all the various selection factors, there's still this finding of better overall survival that's associated with breast conservation. A Swedish study that had the same finding did include almost 6,000 patients with lobular breast cancer. And as was mentioned in the earlier talks, the higher rates of nodal positivity in lobular breast cancer mean that even if a patient undergoes mastectomy, they are likely going to be recommended to undergo radiation. And this can have implications for reconstructive options, surgical complications, and risk of lymphedema if this is combined with axillary dissection. Although some series have shown that there are similar recurrence rates between breast conservation and mastectomy for patients with lobular cancer compared to ductal cancer, one consideration that we have to keep in mind is that these lobular tumors are often much larger than ductal tumors because of that diffuse growth pattern. And the trials that originally tested breast conservation compared to mastectomy did exclude patients with tumors that were larger than 4 centimeters. So we do have some data looking at the outcomes of patients with lobular cancer greater than 4 centimeters in size who underwent breast conserving surgery compared to mastectomy. And you can see here from this Kaplan-Meier curve, we have one group of patients in blue that underwent breast conserving therapy, and this is lobular breast cancer larger than 4 centimeters in size on pathology, compared to patients who had mastectomy alone and patients who had mastectomy with radiation in green. And we see that there is no difference in recurrence-free survival. It is important to note that that the patients with these very large tumors who had breast conserving surgery did have very high rates of positive margins, with more than half of them requiring a re-excision. So this is something that we need to keep in mind, but the long-term outcomes, as long as those positive margins are addressed, are actually similar to mastectomy. On a multivariate analysis, the factors that were associated with increased risk of recurrence, as expected, were larger tumor size, higher nodal stage, and although it's quite rare, the small number of lobular cancers that have the HER2 positive or the triple negative subtype do have increased risk of recurrence, as we saw earlier, but the type of surgery does not end up impacting those long-term outcomes. So if negative margins are achieved, even in the case of these very large lobular tumors, there isn't a difference in recurrence rates for breast conservation compared to mastectomy. Of course, we have to keep in mind more than 50% required re-excision, but I do think that these data combined with the other large series tell us that we should be trying to achieve breast conservation in these patients, because there are so many benefits if we can successfully achieve this for our patients who desire it. So how can we reduce these positive margins? So we did a study looking at the impact of oncoplastic surgery at the time of breast conservation, specifically for patients with lobular breast cancer. And there have been several series showing that oncoplastic surgery is associated with a lower risk of positive margins, likely because it allows for an excision of a larger volume of breast tissue. Additionally, the use of shave margins has also been shown to reduce positive margin rates. These techniques are not always applied, depending on the available knowledge at a particular center, concerns about the time, concerns that perhaps a local center's positive margin rate is not high enough to justify doing these additional procedures. But for patients with lobular breast cancer who have the highest risk of positive margins, these particular techniques may be important. So in this series of 365 patients, we looked at patients with lobular breast cancer who underwent a lumpectomy alone, lumpectomy with the level 1 oncoplastic procedure, and a lumpectomy with the level 2 oncoplastic procedure. And we saw that overall, the positive margin rate was 43%, but the overall rate of successful breast conservation was 75% after patients underwent re-excision. In a multivariable model, shave margins were significantly associated with a reduced risk of positive margins, and oncoplastic surgery, when you combine level 1 and level 2 oncoplastic procedures together, were also associated with a 60% reduction in the risk of positive margins for lobular breast cancer patients who undergo breast conservation surgery. And these results are consistent with other trials and other series that have reported on the subset of patients with lobular histology. One of the concerns that some surgeons have raised with performing immediate oncoplastic surgery is if these patients have a high risk of positive margins and you move around the breast tissue and then you have to do a re-excision, you're not going to be able to do an accurate re-excision. And this could lead to a higher long-term risk of recurrence. So here we looked more recently at the risk of recurrence after immediate oncoplastic surgery for patients with lobular breast cancer. And we had 3 groups of patients. The patients in blue are those who had just standard lumpectomy. The patients in red are patients who had a level 1 oncoplastic surgery. And then the patients in green are those who had a level 2 oncoplastic surgery. In this series, it was most commonly an oncoplastic reduction mammoplasty. And in this larger group of patients, we again found that the oncoplastic procedures were associated with a significantly reduced risk of positive margins, significantly higher rate of successful breast conservation, and most importantly, no difference in the rate of long-term recurrence. And this is important because there are some places where patients with lobular cancer are actually not considered candidates for immediate oncoplastic surgery. And I think that these data are reassuring that it is safe and probably better for these patients to have immediate oncoplastic surgery. And if a positive margin occurs after breast conservation, what is the chance of success for re-excision? So oftentimes we might say, well, we should just go straight to a completion mastectomy. So in a series of 314 patients with lobular cancer who had lumpectomy, of those, 37% had positive margins, and about half of those underwent re-excision, and 74% of those re-excisions were successful, meaning ended up clearing the margins. Now, of course, not all patients are going to want to undergo a re-excision, but for those who desire breast conservation, and because we know that there are advantages in reducing morbidity if we can achieve breast conservation, I think that this is important information when we're counseling our patients on how to manage a positive margin should it recur. And some of the factors that were associated with a higher chance of having a clear margin with a re-excision were older age and having and being node negative. So definitely these are factors that should also be considered when deciding what that second surgery should be if someone has positive margins. So some would look at these data and say, well, you know, this is like a very, very high positive margin rate. This doesn't make any sense. We really should just be going back to mastectomy for these patients. But I think the question is mastectomy really better? Does that solve all the problems? And if you look at the positive margin rates after mastectomy for ILC, interestingly, for those with T3 tumors larger than 5 centimeters, almost 19% have positive margins even after mastectomy. So these tumors are presenting at very high stages. They have a very diffuse growth pattern. It doesn't show up all the time on imaging. So a mastectomy is not necessarily the solution for all patients. So I think that we need to really be questioning whether or not we are doing all of our patients with lobular breast cancer favors by saying that mastectomy is going to be the answer for them. If you have a positive margin after a mastectomy, the risk of recurrence is very, very high, especially if no further local therapy is treated. So this Kaplan-Meier curve, there's very small numbers here, but there's very little data looking at this. This is patients who had mastectomy for lobular breast cancer and had a positive margin. And some patients had additional margin treatment. So these are the patients that are in the red line. So they either had another excision after mastectomy or radiation after mastectomy or both. And the patients in the blue line are those who did not have any additional local therapy to treat the positive margin and instead were relying on the systemic therapy such as endocrine therapy. And there's really a dramatic difference in the risk of chest wall recurrence depending on whether additional therapy is given. So having positive margins after mastectomy is a very problematic situation for patients as well. So I think that what we know is for lobular breast cancer, the diffuse growth pattern combined with the lower sensitivity of standard imaging tools really can hinder our surgical planning, and patients that are diagnosed with lobular breast cancer are facing worse surgical outcomes, higher rates of positive margins, more extensive operations. Breast conservation is safe when we are looking at long-term outcomes, but positive margins are very common. Even with mastectomy, however, if you have a large lobular cancer, there's still a high positive margin rate. So this is really underscoring a great need for better imaging for lobular breast cancer and better systemic therapy to shrink these tumors preoperatively. And we may discuss this when it comes to therapy. There are definitely lower rates of pathologic complete response for patients with lobular breast cancer, but I would argue that pathologic complete response is not the only outcome of interest. And I think this is why other ways of measuring response to neoadjuvant therapy are important, such as the residual cancer burden method, where even if we're shrinking these tumors by just a small amount, that could be the difference between an optimal surgical outcome versus a suboptimal surgical outcome for these patients. So I hope that I have shown you patients with lobular breast cancer have a high positive margin rate after both lumpectomy and mastectomy. For patients who have lumpectomy, I think it is recommended to routinely take shave margins and to routinely offer oncoplastic surgery. If a positive margin occurs, a re-excision has, on average, a 74% chance of success. Even for a large lobular cancer, lumpectomy can still be offered, but it's important that everybody understands that the positive margin risk is even higher. For mastectomy, for a T3 tumor, there is a 19% positive margin rate, and these positive margins must be addressed with additional local therapy, re-excision, radiation, or both. And better imaging tools are certainly needed for this tumor type, and I would argue that there is a potential role for neoadjuvant therapy, even if mastectomy is planned. Thank you so much.
That's great. Thank you for the lovely talk, Rita, and thank you for giving a lovely overview of this. Now, the next talk is Olga, and then after Olga, we'll go for the discussion. It's great to see that 650 people are online. If you have any questions, please put it in the Q&A section because we'll be going through the questions after the Olga's talk. Olga, the next 15 minutes are all yours.
Can you see my slides, Yazan? Yes?
Perfect.
Good, fantastic, thank you. So I'm going to discuss the systemic treatment in lobular breast cancer. These are my disclosures. So most of these key characteristics of ILC have already been mentioned, but in terms of epidemiology, these are mainly postmenopausal women, white Caucasian, about 10 to 15% of all invasive breast cancer, with an increased incidence over the past 2 decades. Often very vague symptoms, ill-defined mass, sometimes mammographically occult disease. The MRI and the ultrasound can certainly improve the detection. The treatment is challenging to achieve surgical excision with clear margins, generally poor response to chemotherapy on the neoadjuvant setting, however, good response to endocrine therapy. However, managing resistance is still a major challenge. So I'm going to focus on the molecular characteristics on this slide because the pathology ones have already been mentioned by Dr. Emad earlier. So for us oncologists, these particular molecular characteristics define or will define the future treatment directions in ILC. So we have inactivation of the CDH1, we have frequent mutations, the PIK3CA pathway, gains in chromosome 1q and loss of the 16. Majority are luminal A cancers, and we know that the luminal A cancers usually they have better prognosis than the luminal B. They are the enriched mutations in ILC are the FOXA1, RANKS1, and TBX3. The most key common gene alterations are in the PI3K pathway, PIK3CA, PTEN, and AKT1, which are present in the 50% of the cases. In terms now of the treatment for invasive lobular carcinoma, there are no specific ILC recommendations, and this emphasizes the importance of research and clinical trials in ILC. This is a very recent paper that was published about 2 weeks ago, and I think it's the results are really striking. I think so far the perception we have about perhaps the lobular cancer is that it's not as aggressive as the IDC. So Magnoni and colleagues, what they've done is they identified all the patients with HR positive, HER2 negative breast cancer between 2000 and 2008. So these were 15,000 patients. They excluded the mixed ILD and IDC patients, and they were left with invasive ductal carcinoma patients 11,981 and invasive lobular carcinoma 1,524. What they've done after that is they identified through these distinct groups the patients that they were fulfilling the high-risk criteria for the Monarchy trial. And the Monarchy trial, as a reminder, is the trial that led to the approval of adjuvant abemaciclib for patients with high-risk disease. And the criteria for the Monarchy trial were either 4 or more positive nodes, a grade 3 cancer and 1 to 3 nodes, or a grade 3 cancer and a disease which was more than 5 centimeters. So they ended up with high-risk IDC of 2,511 patients and high-risk ILC of 361 patients. So these are the groups that they fulfill these particular specific criteria. And then they looked at the cumulative incidence that you can see on the right-hand side of the ipsilateral breast tumor relapse, the axillary region relapse, the distant metastases, contralateral breast cancer, the distant relapse-free survival, the invasive disease-free survival, and overall survival. And by looking collectively, or by looking just at hazard ratios, you will see that there are no differences. There are no differences in terms between the ILC and the IDC. We will see numerical differences in terms of the axillary recurrence and the contralateral breast cancer, which is higher in the lobular cancer. But other than that, the risk of the disease-free survival, sorry, the overall survival, the distant relapse-free survival, and the invasive disease-free survival, they are all the same. I'm sorry, my phone is connected to my laptop. So moving forward, in terms of the systemic treatment of HR-positive, HER2-negative early breast cancer, and this is from the ESMO guidelines, for the luminal A-like cancer, low-risk node-negative cancers, adjuvant endocrine therapy is suggested. For the ones that they have high-risk disease, node-positive disease, really large tumors, grade 3 cancers, these patients will be managed with neoadjuvant or adjuvant chemotherapy. For the luminal B-likes, most of the times neoadjuvant and adjuvant treatment. Now, for the patients that they have the high-risk disease stage 2 and their germline BRCA1, 2 wild type, they will receive, as I mentioned earlier, abemaciclib for 2 years plus endocrine therapy based on the monarchy criteria that led to the approval of the abemaciclib. For the ones that they are germline BRCA mutant patients and stage 2, they have a high-risk disease and they have achieved non-path CR following the neoadjuvant chemotherapy, they will receive olaparib for 1 year plus endocrine therapy. For the metastatic breast cancer patients, the consensus is that all patients with HR-positive, HER2-negative metastatic breast cancer, they should receive endocrine therapy plus a CDK4/6 inhibitor. The data are much stronger for the ribociclib, followed by abemaciclib, and I would say that the data for the palbociclib are negative for all clinical trials. Now, the patients that they are on visceral crisis, not the patients that they have visceral disease, so only the patients that they are in risk of imminent organ failure, they should receive chemotherapy. Now, following the CDK4/6 inhibitor as the first line, and again, given that there is no risk of organ failure, the patients should have fulvestrant plus a CDK4/6 inhibitor if not used previously, or they can have an everolimus, an mTOR inhibitor plus exemestane, or everolimus plus fulvestrant, based on the Bolero trial data. And if PIK3CA mutant, then they will receive alpelisib plus fulvestrant. And we do have a higher rate of PIK3CA mutations in the lobular cancers. If germline BRCA PALB2 mutant, then they will receive a PARP inhibitor. And of course, then on disease progression, after exhausting all the endocrine treatments and the targeted agents, the next line of treatment will be chemotherapy. And of course, most recently, we had the approval of the trastuzumab deruxtecan, an antibody drug, conjugate, and the drug was approved for patients with HER2 low disease 1+ and 2+. Now, what's the role of the chemotherapy in ILC? And my colleagues in the panel previously, they mentioned that there is perhaps less interest about offering neoadjuvant chemotherapy or even adjuvant chemotherapy to the ILC. And certainly, we have data about the neoadjuvant chemotherapy in ALC. We have not seen the good data and the good responses that we have seen in the IDC. This is a paper from a pretty old one from 2012, looking between the path CR rates between ILC and IDC. We can see, looking at all the ILCs, 11% chances of achieving a path CR versus 24% chances of achieving a path CR in the IDC. However, when we look at the HR and HER2 status, like here, HR positive, HER2 positive, we don't actually see a difference. The hazard ratio the p-value is 1. So we don't see a difference between the ILC and IDC. The same for the grade 3 disease. So the clinical pathological features, the molecular features are actually important. But in oncological and MTT oncology, discussing breast cancer patients, highly unlikely that the oncologists will offer neoadjuvant chemotherapy for invasive lobular carcinoma. Another paper, again, focusing on the preoperative chemotherapy and the differences in terms of the responses between the lobular and the invasive ductal breast carcinoma. Again, from 2003, when we look at the overall response, the overall response in the IDC was 70% compared to the 50% for the ILC. And when we look at the path CR rates, 50% in patients with IDC and 0% in patients with ILC. Now, the questions that I think they are still, they create a bit of, not confusion, but sometimes a bit of anxiety in oncology about which patients we should treat if they have ILC or IDC. What's the role of the Oncotype DX test? The Oncotype DX test, I'm sure you're all aware, and you've all seen that in your MDTs. When we request an Oncotype test in a patient with a lobular cancer, most of the times the Oncotype RS score is coming back as a low. low. And this is perhaps because of the very low proliferation. I mean, we don't have too many cases in the premenopausal women, so this is small. Again, the question is, what is the role of the ovarian suppression and endocrine therapy versus chemotherapy in premenopausal women with a lobular carcinoma? And again, the postmenopausal women that they have a grade 2 cancer node negative, should they receive tamoxifen or letrozole? And I will discuss the endocrine therapy in the next couple of slides. And should the management be different based on the IDC versus the ILC diagnosis? And what about the pleomorphic ILC? Certainly when I see pleomorphic ILC, my instinct tells me that I need to treat these patients in a more aggressive way compared to the classical lobular carcinoma. And I showed you that this slide earlier on, suggesting that there are no differences in terms of the IDFS, the DRFS, and the overall survival between patients that they have ILC and IADC, and they carry high clinical pathological risk features like patients with more than 4 positive nodes, patients with grade 3 disease and 1 to 3 nodes, or patients with grade 3 disease and more tumor more than 5 centimeters. And I think this is an excellent paper from Len Nelson looking at the SEER database, identifying all the patients that they meet the monarchy criteria. So they group the patients, more than 100,000 patients that they fulfill the criteria, and they group it based on the monarchy trial criteria. So the patients that they fulfill the monarchy trial criteria are the ones in purple dotted line, and the ones that they are with black or gray is the TNBC. And what we can see here, which is very striking, I would say, is that the patients with HR positive, HER2 negative, early breast cancer who met the monarchy high risk criteria had a similar risk of mortality as those with triple negative breast cancer. And we should not forget that there is an ongoing rate of distant recurrence in HR-positive early breast cancer. So looking at the grading, for patients that they have completed, this is a meta-analysis from Panelists, which was published in New England Journal of Medicine in 2018. For patients that they've completed 5 years of endocrine therapy and they were disease-free on year 5, looking for the distant recurrence percentages based on the grade, high, moderate, or low, up to 20 years, there is still a 17% distant recurrence percentage for the patients to have a recurrence compared to the 10% for the patients with low-grade disease. And when we look at the distant recurrence based on the nodal disease, so N0 means negative lymph nodes, N1, 1 to 3 positive nodes, and N2, 4 to 9 positive nodes, there's a 52% chances of distant recurrence even 20 years down the line for patients that they have 49 positive nodes. So going forward and discussing endocrine therapy in ILC, I'm based in Edinburgh, and our surgical team is led by Professor Mike Dixon, who is I would say, huge fan of neoadjuvant endocrine therapy. He published a lot in that field. And one of his papers, again, from 2011, is the one that you can see on my screen. So this is the response of ILC to the neoadjuvant letrozole. What we can see, and the patients were given neoadjuvant letrozole between 3 and 9 months. So the 3 months percentage reduction in the volume mass was measured clinically by calibers for 60 patients. We can see in that kind of graph. So 36.7% of the patients achieved a reduction in the clinical tumor between 75 and 99% in 3 months. 15% achieved 100% reduction, so complete radiological and pathological response to the neoadjuvant letrozole. So certainly the neoadjuvant letrozole for patients with node-negative disease, it's something that we do a lot in Edinburgh. I'm not sure how common is that outside Scotland and in the rest of the country or outside UK, but certainly these data and what we have seen so far is that it definitely facilitates a surgical plan. Now, in terms of the adjuvant endocrine therapy, I think it's common knowledge that the letrozole is the preferred option for patients with ILC, so invasive lobular carcinoma. Here we can see a paper that was published from the data in Big 198 in JCO in 2015. So we see the disease-free survival on the left, and on the right is the overall survival. The dotted lines are for lobular, and the continuous line is for the ductal. And what we can see is that for overall patients with ILC have a greater benefit from treatment with letrozole rather than with tamoxifen. Across the 8 years of follow-up period, the DFS was reported as 66% for tamoxifen versus 82% for letrozole in patients with ILC, and the overall survival was 74% with tamoxifen compared to 89% with letrozole. Going into deeper waters now, looking at the molecular features and mutational signatures, the breast cancer with ApoBec mutational signature are linked to the lobular phenotype, and they have a high mutational burden, as we can see here. This was a very good talk from Mara in ESMO about 2 years ago. So the ApoBec and the HRD are associated to the endocrine resistance. What we can see here, if we look specifically at the ApoBec, and these are patients, and this is the progression-free survival on first-line endocrine monotherapy. So the median progression-free survival for patients that they have ApoBec mutational signature is only 9 months. And going forward, looking at the ones that they had endocrine therapy plus CDK4/6 inhibitor, this is only 12.3. I will remind you here that the median progression-free survival for patients on single monotherapy, and as was seen in all the CDK4/6 phase 1 trials, including palbociclib, ribociclib, and abemaciclib, the progression-free survival for the placebo, which was the single monotherapy, was ranging between 12 and 14 months. And for the patients that they had CDK4/6 inhibitor added to the endocrine therapy, this was doubled. So the patients had about 28 months between 26 and 28 months of median progression-free survival. And what we see here is that the ApoBec signature significantly reduces, suggesting endocrine resistance. PIK3CA mutations are enriched in the ApoBec dominant breast cancers, and here we can see the double PIK3CA mutant breast cancers in the ApoBec signature, and obviously this informs the decision making about the targeted agent that will be offered to the patient following disease progression on the CDK4/6 inhibitor. So the HR-positive, HER2-negative breast cancers, they acquire genomic instability during tumor evolution, with the ApoBec and the HRD likely being the main drivers. And we do know that the patients, the cancers, they have a high genomic instability, will not respond well to the endocrine therapy, then they will require chemotherapy. The breast cancers that are high levels of ApoBec mutagenesis are characterized by high mutational burden. As I said, they're usually lobular cancers. They have specific mutations like in PIK3CA, CDIH1, NF1, and PTEN. They have a shorter progression-free survival on first-line endocrine therapy in combination with the CDK4/6, and the patients with HRD, again, dominant HR-positive, HER2-negative metastatic breast cancer, have shorter PFS on first-line endocrine therapy plus CDK4/6 inhibitors. Talking about the PIK3CA mutations, the SOLAR-1 was the first study that looked at the role of the alpelisib in patients that they had a PIK3CA mutation. However, on this study, we didn't have enough numbers of patients that they were exposed to CDK4/6 inhibitor as the first line, and therefore we had later on the BYLieve study, which was the addition of alpelisib in patients that have received prior CDK4/6 inhibitors. So the patients receive alpelisib plus fulvestrant, and what we have seen, is that there was an improvement. The primary endpoint for the prior CDK4/6 inhibitor plus AI cohort was met, with more than 50% of the patients being alive without disease progression at 6 months. Now, the focus now, and obviously talking about endocrine resistance, is ESR1 mutation. There is no pharma company that has not invested on developing a SERT. The first one that has been approved, and this is FDA approved, is the elacestrant, based on the Emerald trial phase 3 study. versus the standard of care. So the patients following disease progression in 1 or 2 prior lines of endocrine therapy, they have received elacestrant versus investigators' choice of fulvestrant, anastrozole, letrozole, and exemestane. When the investigators looked collectively at the data, these were not really fascinating, but when they looked at the ESR1 mutant tumors, and they specifically on the groups of patients that they responded well to the CDK4/6 inhibitors, they saw a median progression-free survival of 8.61 months versus 1.91. And for the patients that they respond for more than 18 months, again, more or less the same, which suggests that the patients that they have a good response to the CDK4/6 inhibitors, if they are exposed to elacestrant following disease progression CDK4/6 inhibitor, they will have a good progression-free survival on the second line. Now, future directions in ILC, new targeted agents, Serena-2, phase 2 trial of camizestrant versus fulvestrant in patients that they have progressed on 1 line of endocrine therapy. They shouldn't have received fulvestrant or any other oral SERD before, and they could have had 1 line of chemotherapy. They were randomized to receive camizestrant 300 milligrams or 75 or 155 or fulvestrant. And looking on the right, the progression-free survival, 12.7 months for the camizestrant of 150 milligrams. So higher than the elacestrant, and also not specific to ESR1 mutant cohorts. These are multiple novel oral endocrine therapies currently in development, which are investigated both on the metastatic but also on the neoadjuvant and adjuvant setting. There are only very few ongoing trials in ILC, and these are summarized here, at least, on my knowledge. The preoperative trials for newly diagnosed patients, again, ILC specific, the PELOPS enriched for ILC, and trials for patients with metastatic ILCs, the ROLO and the Gelato. The TBCRC 037 patients are randomized to receive tamoxifen and anastrozole fulvestrant, and we're looking at the Ki-67 after 3 weeks of endocrine treatment. The ROLO study is investigating the role of crizotinib in patients that they are ECAD negative, AR positive, HER2 negative, and they had up to 3 lines of treatment. Patients previously treated for advanced lobular cancer. The crizotinib is a tyrosine kinase inhibitor focusing on ALK ROS1, and it sounds as a promising new agent. Now, the Gelato, which has been reported and presented, I think in August 2023, not really fascinating study. They were looking at the role of immunotherapy in combination with carboplatin in metastatic lobular cancer. They gave carboplatin as an induction for 2 weeks to the patients, and then they added atezolizumab for up to 3 months. And what we can actually see here are the patients, they had some partial response, are the ones that they were lobular breast cancers, but they were triple negative, which was expected. These are the future directions in ER positive, HER2 negative disease, multiple new agents, AKT inhibitors, novel antibody drug conjugates, immunotherapy. So it's multiple paths with multiple approaches. And that's my last slide. ILC represents a biologically distinct subset of breast cancer. The unique biology directly affects the initial presentation and makes the early diagnosis challenging. There is evidence that the use of an aromatase inhibitor such as letrozole should be the treatment of choice. We have multiple lines of treatment with targeted agents on the metastatic setting. The PELOPS clinical trial is still investigated. However, given the negative clinical trial data from all palbociclib clinical trials, I don't have really high hopes. The CDH1 gene mutation is involved in the pathogenesis of ILC, and we have multiple therapies targeting the PI3K pathway. Understanding the unique biology of ILC is essential to facilitate the development of novel therapeutic strategies moving toward precision medicine for patients diagnosed with all subtypes of ILC. Thank you.
That's a great talk. Thank you, Olga. You told me this is last minute slides. So what what would you have done if it wasn't last minute slides? That's nearly the whole literature. Thank you for that. And now we have a discussion, great points to discuss. For people online, there is a, if you join the newsletter, I'll always send you details about things, but there is 10 discounted places in the Uppsala breast meeting, which is with Andreas in Uppsala in Sweden in May. The link for that registration is there. There's only 10 places for that discounted rate. And there is also the Association of Breast Surgery meeting in Bournemouth this year. I'm the meeting secretary, so it will be great to see many more people coming from outside the UK to attend the meeting. It's always a great meeting, and we have about 6 international speakers. Now, quite a few points to address. I think there's lots of things on the question and answer section. Just to mention one thing, don't email me in the next few days. I will send you the certificates or the CPD points in the next few days by the end of the week, hopefully. Now, we have Martin with us and we have Andreas, and there's lots of questions on the Q&A section. Martin, any comments?
Yes, that would be a lot of points to discuss, but I just want to make a few remarks regarding surgical approach. As we heard, lobular cancer is an entity that has a different presentation, different prognosis, and also a different recurrent pattern from NST. Also, in terms of axillary involvement, several studies reported a higher nodal stage at diagnosis, with up to 38% of nodal positivity, also in clinically node-negative patients, highlighting the challenges of a clinical node assessment in ILC. But the current trend in surgery is to de-escalate breast surgery cancer treatment, especially regarding axillary surgery. The SOUND trial showed no benefit of axillary stadiation for breast cancer lesions under 2 centimeters and clinically node-negative patients. Just a few days ago, results from the Xenomac trial were published in the New England Journal, showing no benefit from axillary dissection in patients treated for T1 to T3 breast cancers and up to 2 macrometastatic nodes, even in cases that were missing in the ICOSOG and AMAROS trials, such as mastectomy or extranodal invasion. The point is that in both studies, ILC population is underrepresented. In the SOUND trial, were 8%, and in the Xenomac group trial, around 20%. So the feeling is that maybe we are missing something regarding lobular treatment, and specifically regarding axillary de-escalation. And maybe we have to produce further evidences in the next year to allow also lobular breast cancer to receive a clear surgical de-escalation as NST breast cancer patients.
Any comments on that, on de-escalation of the axillary surgery, Rita?
I think that those are all very important points, and the small, I think, analyses trying to look at the lobular subsets in these trials, I think, have shown that omission of axillary dissection doesn't seem to cause more problems for patients with lobular breast cancer, but the numbers are very small, as Dr. Sanchez just said. The outcomes need to be longer because the timing of recurrence can be late for lobular breast cancer. But I think that, we know that even an axillary dissection is not really going to clear all of the disease if you have a very diffuse growing tumor. So it makes sense that if you can surgically remove the gross disease and you're going to have to rely upon radiation and systemic therapy after that, you have to wonder, is it good to be giving patients the risk of complications from such extensive axillary dissection if you're not really getting rid of all of the disease anyway? So I think these are very important questions, and 100% I agree that we need studies looking at lobular specifically, more numbers of lobulars, because it is true that the growth pattern is different, and this has been the whole challenge is all of the way that we manage breast cancer is based on trials that include predominantly patients with invasive ductal carcinoma. So it's very important that we are questioning this and trying to accumulate the data for lobular breast cancer specifically.
So let's stay with the axilla just for slightly a bit. I'll give you a couple of minutes, Andreas. Just let's say the axilla, just quite a bit in lobular. And let's go to pathology. So sometimes, even on pathology, on HNE, it's negative axilla. You need to do immunohistochemistry to confirm that there is positive axilla. Am I correct in saying that? So even grossly, it's difficult to see what's happening there. Emad.
Yes, yeah, it is difficult in lobular, and sometimes we need the cytokeratin to demonstrate the existence of lobular cells in the lymph node. But the point is what I want to highlight here is the clinical trial is mainly after surgery. So you have sentinel lymph node, which was diagnosed as clinically negative, maybe with or without biopsy, and this is confirmed to be negative, and then surgery, and then histology, and then the result of the lymph node is positive. So do you need to have axillary surgery, second axillary surgery or not? But what about intraoperative assessment? Because we have many places where they send the lymph node for intraoperative assessment. So this is important, especially in lobular, because if you have one or two positive node, should you stop and accept that you will go for radiotherapy, or should you continue sampling more nodes? So my point here is we have to be careful with lobular, not to say yes or no, but to be careful that you may have more positive node that is missed in the not felt, the surgeon will not feel it. And so maybe our approach in lobular to take more node to make sure that we have, for example, 5, 6 nodes, and out of those 1 or 2 positive. But if you have 4 out of 5, this is a lot.
So,
not to stop at a small number of nodes.
But we need to be careful, but not to be paranoid, I think, if that makes sense. We're treating biology, we're not treating anatomy. And the tricky bit in it here, also, Tamara, you do ultrasound scans for the axilla, and most of the time it's negative. And if you find 1 or 2 positive nodes in an axilla that is lobular, you know that you'll have a nightmare intraop. You know that you'll be not 1 or 2 nodes that are positive. Am I correct in saying that?
Yeah, I mean, I think if often, as I said in the talk, often when we're looking at the axilla, it's in that first meeting with the patient, either after a screening assessment and a recall, or when the patient presents and we're looking at the breast and we look at the axilla. We don't know at that time that the patient has lobular. We take a biopsy and it comes back later as being lobular. But we should then consider going back and re-evaluating the axilla very carefully with ultrasound. And I think maybe that doesn't happen as often as it should. And perhaps we take a pre-operative core biopsy to try and assess the axilla. It's more procedures, but we have to drop our threshold with lobular.
Perfect. That was my daughter just coming to give me a key. I don't know. I'm locked out of the house now. Andreas, any comment on that?
Yeah, well, these were very, very clear talks, all 4, and very sensible and clinically relevant. I think that from a completely practical standpoint, with regards to how we as surgeons tend to deal with these things, my 5 cents are the following. I think that when it comes to dealing with lobular breast cancer, you need to be reviewing your imaging, aiming to remove probably what is clearly not physiological as opposed to what is clearly pathological, because as Tamara said, even the MRI, which we predominantly do in lobular cancers, is failing us a lot of the time, and really all studies, or no randomized trial has been able to show any advantage, and even observational studies that are focused on lobular cancers do not succeed in showing a reduction in re-excisions when doing breast conserving surgery. On the other hand, we should not be resorting to mastectomy. Rita very elegantly showed that there is no point in trying to overtreat to be able to achieve better results. Primary systemic therapy. What the Edinburgh approach has been all these years, I think, should be a paradigm of how we should start thinking around the disease. There are a lot of questions in the chat why should we give neoadjuvant chemotherapy and when do we do, and why does lobular respond poorly to that? Well, the reason is that actually, if you've got a bazooka, it is much easier to kill an elephant, but not a cockroach. And invasive lobular carcinoma is a pack of many cockroaches, and then you will probably miss over there. Along with the fact that the MRI that we usually monitor these patients with has a low specificity, meaning that lesions that do not have high metabolical needs will not have uptake in the MRI. I hope Tamara agrees with the comment on that. Yeah, thank you very much. My questions are the following, and I've got one for each, and I would like to start by asking Tamara about something that she touched upon. You said that sometimes we do the MRI and then we have to go back to the axilla, and you have already said that the axillary ultrasound is less reassuring. What is your personal experience, because the literature is a little bit scarce, about a negative axilla clinically, positive or suspicious on the ultrasound, with regards to what comes back on pathology?
So this is difficult as well, because we don't concentrate on looking at just the lobulars. And I think this is throughout the literature, the problem that we don't have enough data on just lobular. But we know, we've audited what we've done at our institution, and we've seen that the false negatives assessment that have come back as positive at sentinel node have often been lobular, where it hasn't created this bulge, this abnormality, and we get this diffuse thickening. Now that is really challenging for ultrasound, because we've then got to figure out, do we have another cortical thickness threshold? And we haven't even established, in the UK, we haven't even established what a abnormal thickness is. We hope to resolve that. We're doing a big national audit this year, and we might have some more information on what we choose as a cutoff. And it may be that we have enough data to be able to provide a cutoff for lobular, a cutoff for NST. But when we have the MRI, we have the ability to look at all of the nodes sort of simultaneously, review them, so we can pick out at least one or two that looks slightly different. And I think then you go back to the ultrasound and find that node and biopsy it. You have to tailor it. You have to tailor it for lobular.
Thank you. Now to Emad, on the same topic, Yazan touched on it, and you already said that we would need, say, CK-MNF and so on. So just from a pedagogic standpoint, may the reason be for this elusive appearance that as the primary, the metastases as well do not have cadherin expression, so that does not deform the node in the traditional manner that we expect?
Yes, the lobular in general, they all lose e-cadherin. So they all this cohesive growth pattern and diffuse. That's why it is difficult to be identified, because they are cells, similar to leukemia, for example. Imagine you are dealing with leukemic infiltrate. Unless you have a mass of leukemia, it will not be detected on imaging. So it's just infiltration by cells. So
Okay.
it is difficult. And I wanted to add something just for clinicians to understand, because the topic of luminal. Lobular is unique because lobular is luminal, but not similar to ductal luminal. Ductal luminal, two types. Low-grade ductal, very good outcome, regardless of treatment. High-grade ductal with luminal type, highly proliferative, and they respond to chemo. So you are dealing with a unique entity of tumor labeled as luminal, ER positive, HER2 negative, but they are not similar to low-grade luminal ductal or high-grade luminal ductal. So it is a bit of, and this is, you need to consider this.
Thank you very much. Now, I will leave the surgeon last. I will go to Olga, and I will ask, there is this discussion about neoadjuvant, like primary systemic treatments. We also implement preoperative endocrine therapy extensively in women with a lobular breast cancer, especially if they're postmenopausal, and there is a question of surgical de-escalation over there or facilitation of surgery. With regards, you showed that ERBB2 status, if positive, does not differentiate the outcomes in lobular. So the difference is what we would call luminal B-like tumors most often. What would your approach be in this case?
So what would be my approach for luminal B cancers, regardless of, the histological subtype, you mean?
No, we are discussing about an established diagnosis of invasive lobular cancer,
Okay.
which is
ER positive, perhaps PGR0, and has a Ki67 of high or low PGR, and
let's make it
luminal B.
extreme. ER80, PGR0, Ki67, 46%.
So what would be my approach? So first of all, this case will be discussed at the Oncology MDT, okay? And usually the concept is that there is a fight between the surgeons and the oncologists about offering neoadjuvant chemotherapy, because all of the surgeons are very fond of neoadjuvant chemotherapy. And the oncologist will probably say, if the tumor is small, node negative, take it out. If the disease is node positive, the tumor is large, and offering neoadjuvant chemotherapy will reduce the tumor burden, facilitate the surgical plan, and perhaps save the patient from having axillary node clearance, then I will accept to offer neoadjuvant chemotherapy to this patient based on the ER positive, very low or zero PGR negative. These patients will respond better compared to ER8, PGR8, okay? And my concern with lobular cancer, let's say there's a large lobular cancer, node negative, and let's say there is a surgeon that insists of having neoadjuvant chemotherapy. I'm always thinking about the impact on the stress that will be caused to the patient by offering chemotherapy, and the patient coming back at the end of the chemotherapy, having all the neoadjuvant chemotherapy, radiological imaging, having the same cancer, no reduction, no downgrading, no downstaging. So I'm always, very, very cautious when it comes to offer neoadjuvant chemotherapy. But in this particular case that you mentioned, if the patient fulfilled the criteria of node positive disease, large tumor, I would consider chemotherapy.
Okay, because I'm asking about that because, the only way that a surgeon can affect survival in breast cancer is by worsening it, by giving larger surgery with complications that will delay systemic therapy. That's the idea.
I understand, yes, completely agree.
And having said that, so sometimes neoadjuvant is a very valid maneuver from that, because there is less guilt if the patient has gotten their chemotherapy up front. Whatever you do, you cannot harm them significantly. Yazan is laughing. So having said that, my last question is to Rita. Rita, fantastic talk. Thank you very much for that. Your experience with invasive lobular cancer is well established. I would like to ask another thing, which is a little bit more controversial. In light of the recent publication from last year of the Z11102 Alliance study about breast conserving surgery for multifocal tumors and separate excisions. So they had a very low amount of lobular cancers that successfully made it. What would your approach be? Let's say that you've got an MRI that speaks of 2 separate foci, and it is technically feasible to do a reduction mammoplasty and just, remove 2 separate bits. It is also technically feasible on that patient to remove the entire footprint. What would you go for and why?
Yes, thank you. So in my experience, most of the time when you have a multifocal or multicentric lobular cancer, usually the tissue in between the tumors also has scattered invasive lobular cancer cells. So I think it's better to take out everything in one piece if possible. I do think that there are some features of the MRI that you can look at that might help you feel more confident or less confident. So people have written about the tumor phenotype on MRI. So does it form just a mass? Is it just non-mass enhancement? Is it the mix of the two? I think that if there is any non-mass enhancement, the MRI, you really cannot trust the MRI, if there's any non-mass enhancement. If it's just like two solid masses, maybe you could get away with two separate lumpectomies, but I think it's unlikely to work. So for me, I would consider all of the tissue in between to have a high likelihood of also having cancer cells. And I think I would recommend taking it all out.
Similarly, let's suggest that you are going for the ER-positive, HER2-negative luminal B-like breast cancer that you spoke with Olga some months ago, and she agreed on neoadjuvant chemotherapy. And then you've got an MRI that shows almost complete radiologic response. Do you go for the clip or do you go for the footprint?
You have to take the whole footprint because these tumors, they don't shrink concentrically.
Exactly.
I think that you do. I do believe, I guess I'm like the typical surgeon. I think neoadjuvant is good. So I think that they do shrink, but they shrink in like Swiss cheese, like you get holes in the tumor within the same footprint. So if the pathologist will report the cellularity of the tumor, the cellularity will often be very low. It's just scattered over a large area. And I think it's very important to share this with patients, because I think one of the challenges with when we say that there's no response to neoadjuvant therapy for lobular cancer, it's sort of an unfair comparison, because what we say, oh, on the MRI, the tumor is 3 centimeters. Now you get neoadjuvant, we do surgery, and it's still 3 centimeters. But in fact, it was probably bigger than 3 centimeters, right? It was probably bigger than that. And we just didn't know that. And then, of course, I think that this is an approach that many people have brought up, I think even in the chat that's, I think, used in the UK all the time is, we do a lot of neoadjuvant endocrine therapy because that is something that, for this case that you just brought up with a high Ki-67, looking at the change in the Ki-67 could influence what you're going to give adjuvantly. So that is also an approach that we use a lot. Maybe not for Ki-67 of like 40 something, but if you're in that Ki-67 of like 15 to 30% range or something like that, and then you can see that it drops, I think that is very useful information.
So that's great.
Very much. Thank you very much. I just wanted to say that with regards to the escalation, let's keep in mind that in many cases, Rita showed that very well with the mastectomy for T3s being with positive margins in 20% of patients. Sometimes it is meaningful de-escalation not to avoid the mastectomy in the end, but to facilitate a safe immediate reconstruction, for example. So we need to put all these parameters into the equation and inform our patients on our decision making, and that should be multidisciplinary, of course.
Yeah, nearly 18% of involved margin in T3s of lobulars is significant. And the last thing you want to do is to do mastectomy and reconstruction and find that anterior margin is one of those 18%. And what are you going to do now? End up having more problems rather than solutions. Also, the other thing is that not all lobulars are the same. For example, for me, invasive pleomorphic lobular is different. For me, HER2 positive, which you see every now and then, is different. And for the HER2 positive lobulars, I will take that diagnosis with a pinch of salt. Is it really lobular or not? But most of those will be pushing our oncology colleagues to give chemotherapy. For the ones that are triple negative lobulars, and you see that also every now and then, and you think, is it really a lobular with triple negative? Also, we'll be speaking to the oncologist about giving chemotherapy. Am I correct in assuming that, Olga? You'll be happy with the triple negative lobulars, you'll be happy with the HER2 positive lobulars to have chemotherapy. So just the label of lobular does not mean no chemotherapy.
Absolutely.
And Martin, do you do anything differently in Italy, or is that roughly the same way of addressing things? When they're triple negative with a HER2 positive, you push for systemic treatments first. And if they're small, for example, luminal, then you start with surgery first and see how things go.
No, it's the same. We of course discuss every case at MDMs, but the approach is to remove lobular breast cancers when it can be done with a safe surgical procedure, independently of what we have
Because I
on the table. Yeah,
always feel uncomfortable with a large lobular triple negative or HER2 positive not to give them systemic treatments. What about you, Andreas? What do you do in Uppsala?
A HER2 positive is a HER2 positive, and we saw that it will respond this way. A triple negative, even much more of a rare species. If it is that, then it is treated as a triple negative. With regards to the approach of neoadjuvant therapy, we just need to be very clear with ourselves within the MDT and towards the patient what the goal for that is. So one goal for me always is what I said. I think that surgeons, we should stop hallucinating and feel that the knife prolongs survival. And we need to, if you have a patient in front of you that will require very aggressive surgical treatment because of advanced disease and systemic treatment, it is only reasonable that you go for what they need first, and it is the systemic treatment, and then do whatever you do, regardless of what you expect in terms of de-escalation outcomes. And the patient needs to be informed about that, right?
So it needs to be realistic expectations. You might not have the same type of response. You might not.
I would never promise anybody with an invasive lobular cancer that go for chemotherapy first, that, okay, we're doing a clipsectomy and it's going to be fine.
That's a key message. Yes, you give it, but the message for the patient might be different. Yeah. We have only less than 10 minutes left before we close this. Martin, is there any points that you want to address?
No further points. Okay. No further points.
And I think one important thing that Andreas and Rita has mentioned is if you have multifocal lobular, you always have the heart sink. When you take it out, it's usually one big problem rather than multiple small problems, or multiple small problems with lots of LCIS in between. Another important thing that Emad has mentioned, people don't know much about it. We have established as pleomorphic lobular pleomorphic LCIS is treated like DCIS, and we have published on that, and most people are treating pleomorphic LCIS like DCIS, which is great, but not many people know about florid LCIS, that it should be also excised as DCIS. The mass forming part of it needs to come out, and if it's florid LCIS, if there's anything on the margins, as long as it's classical LCIS, am I correct in saying that, Emad? It's okay, but if it's still a florid variant, you need to go back and take more. It's different beast. It's not classical LCIS. Am I correct?
Correct, definitely. But I want to just to add, there should be a communication between surgeon and oncologist and the pathologist.
Yes.
And when you get mismatch results like lobular triple negative, you need to investigate why it is lobular triple negative. You need to exclude possibility of being false negative or being not lobular, or being a rare variant of lobular like signet ring or histocytic, which is very aggressive. The second thing that we need to add with Andreas and Olga is the neoadjuvant. The point is, if you have 50% of patient, the idea is not surgery. The idea is delaying surgery for 6 to 8 months with a tumor that will not respond to treatment. So you need to consider this is not just the impact on surgery early or surgery or no surgery, but the time of surgery. So you need to be careful. That's why you need to have discussion case by case basis for the what type of lobular. Is it classic or is it aggressive type? So grade 3 lobular, HER2 positive lobular, ER negative lobular, or polymorphic lobular, or classic lobular. And second, do you need to have, this is something that we need to discuss. If you have two questions, if you have low oncotype DX, but high clinical risk, what should you do regarding chemo? And second thing is, is it possible to give neoadjuvant If you decide to give neoadjuvant, is it possible to assess after 3 months or something shorter time? If there is no response at all, to go for surgery, or you have to continue like what we do with the ductal type?
So there's lots of points, and unfortunately, with the time, we will not be able to address that. And also, another important point with lobular, I think what they've done in Edinburgh with Prof. Dixon and the team with neoadjuvant endocrine is magic. I think it's underused. I think with the EndoNet now in the UK starting to look at neoadjuvant endocrine, I think in certain biology, you will start finding that it really makes a difference. I think there's only 5 minutes left. So any final comments from any of the speakers or the panelists? Martin, you did not say much today. So is there anything you want to mention? No,
I would like to also discuss about margins and what to do with inside to involve margins, but there's a lot of stuff and we don't have time. So maybe we will have to do another connection, another meeting about that. Yeah, the margins is always tricky also in lobular and beautifully addressed by Rita. Any other comments by anybody? Perfect. So the next webinar is on the 4th of May. It's in 4 weeks. It's fluorescence in breast surgery. We have the lovely Alberto Rancati from Argentina. We have Fernando Dip from Argentina, Gemma Pons from Spain, Rutger Scholz from the Netherlands, Martin Newman from the USA, Jacqueline Rica from Panama, and of course the usual offenders. We have Ricardo, Pardo, and hopefully Tatiana also will join us for the Russian channel. Everybody will get their certificate in the next week or so. So I cannot thank you enough for the panelists and the speakers for giving up your time being with us on a Saturday today. And for people attending, thank you for still more than 500 people online. So for people in the States and South America, have a lovely day. For people in Europe, have a lovely evening. For people in the Far East and the Middle East, have a good night. Thank you, everybody. Thank you.